Good evening, everybody. It's a case of myopic phobioschisis with ERM, with vitreomacular traction, with cataract. My plan was to do phaco IUL, vitrectomy, ERM, ILM removal. And after just completion of phaco, I have seen that a lot of vitreous hemorrhage was there. It was totally unexpected thing for me because pre-operatively I was seeing I have seen the fundus, and I have taken the OCT also, but a lot of blood clot is there pre-retinally, and I tried to gently lift up the blood clot, removed all the blood clots from the retina. And now discovered that there is a slit-like break in the infrared area. You can see a lot of subretinal hemorrhage, which was totally concise to the infrared area. Might be a case of globe perforation that happened in the anesthetist's hand. So I did fluid exchange. It was a high myop case, so I injected dye under air. Usually, generally, I'm not giving it in the fluid. It is not under air. But when I am starting the infusion on to prevent the jet injury, I keep my cannula in front of the jet, but still some kind of detachment happened superiorly, and I have seen there are multiple breaks superiorly. However, I have to finish the sphobia part. I was supposed to peel the ILM and ERM and ILM both. So I started peeling the ERM, which are already quite decently stained nicely, and I peeled the ERM followed by ILM in the schisis part because there was VMT and schisis changes. And the difficult situation in handling the myopic phobioschisis part is high myop, more than -8 diopter myopia, and you can see the multiple breaks are there. There is subretinal air is there also. So I started doing cautery at the margin and superior breaks. I unified all the breaks into single break, started doing fluid exchange. Started doing fluid exchange and make the retina on, and then did laser around the breaks and completed a fluid exchange. And postoperatively, you can see after 2 weeks, patient gained 6/12 vision, and after 6 weeks, gained 6/9 vision.
So again, very nice case, and I think this brings up a couple of points. Is maybe we'll go down the panel.
Peribulbar block in high myop.
Yes, yeah. So for each of the panelists, we'll start with Manish, then Shobit. Who do you do your own blocks, or anesthesiologist does their blocks?
My anesthetist does the blocks, but we do let him know, especially when there's a high myop. We make sure that he is extra careful in those conditions. But the anesthetist gives it at my place.
Hemant?
Yeah, my anesthetist does the block, but she does it in the she does the episcleral block. She calls it the episcleral block, which actually basically is the subtenance type of block in which he does not come towards the globe. So, and I always tell them, she always looks up and says, this is a high myopia, or they have been buckled previously. She's always aware of it. So she takes care that in those cases, especially because globe perforation is very common in them.
Shobit and Pramod,
I do my own blocks myself, or my fellows do it. And we have a special note. We see first whether the patient is a high myope. The technique I use is the same which Manish's anesthetist uses. A 26 gauge needle, first to infuse subcuticular, a little bit of amount, so that the rest of the block is not painful, and it's a peribulbar, very shallow block. It's not a deep needle at all.
Pramod?
Yeah, same thing. For us, anesthetist gives block, and anesthetist was specifically, we tell them that yes, it is high myop, this is axial length, and he is having a stapyloma or not. We keep them informed. It's again peribulbar block and a medial conal block. That's what we give. But what is more important, we can have a perforation with medial conal as well. But important to keep them informed that this is high myop patient. Probably I was also having added stapyloma we are dealing with. That knowledge is important.
Yeah, we do a subtenance block, as Dr. Hemant mentioned, and our fellows do it for us. And yes, in any time we have a high myop or a post-buccal case, there's a special note and a special note warning the fellows about that, and they take care about that.
After this case, I started giving subtenance blocks in high myop myself. I am
Okay.
not. I am
You
not
take
depending on
chance.
the anesthetic.
I'm
I
sure you
myself
do.
giving block, especially in the high myop, intranasally subtenance block. It's coming within few seconds, beautifully, within 20 seconds.
I pretty much do all the blocks. I do the opposite. I let the fellows do everything else except the block, because the block is the most important part that I can't see what they're doing. So I do the blocks all myself. And most of the people in the US, I would say 95%, they do their own blocks. Because of this particular issue, there have been multiple lawsuits of anesthesiologists being sued. And for so every country has different ways of doing it, but I would say for me it's the opposite. I do all the blocks, my fellows do all the surgery with me, and with my supervision, obviously. But you know, it's important to realize that block complications can occur, and especially you showed a nice case of a high myop. You can see the atrophy, and so on and so forth. So these can be, now luckily they were looking in a certain direction, so you had them. It didn't injure in the posterior pole, right? It was nasally. That's usually where you kind of see it, because as they're doing the Bell's reflex, right? You're going temporal to nasal, however you're doing it. So, but I think, again, lesson to learn that simple parts of the procedures that you think are simple can have the most problems. So, any other comments before we move on? Anand?
Yeah, we can move on. Sai, can you?
So this is a video showing two cases of myopic RDs with different, degrees of subretinal bleed. Now, these myopes were blocked by me. They are non-hypertensive, but they are very high myopes. The first case shows, this blood at the posterior pole, and when the vitreous was a little hazy, and after completing the vitrectomy, you can see clearly the posterior, the streak of bleed there. There was no perforation in this case. We proceeded with vitrectomy, and as it was a mild amount of bleed, we just injected some PFO at the posterior pole to limit the bleed, and all the maneuvers like laser and oil tamponade was done, and that contained the blood. It did not increase after injecting the PSC at the posterior pole. The second case, however, a similar high myop case, and to begin with, it had a large and diffuse subretinal bleed, and there was a large temporal lattice, as you can see, with a large break, and that did not, of course, it was already very diffuse, covering all of the subretinal space. So we injected again PFO at the posterior pole, and we had to drain all the heme through the temporal break. And as you can see, after the PFCL injection, all the blood came into the vitreous cavity through the breaks, and the rest of the bleed was drained, and we made an additional retinotomy at the posterior, near the posterior pole also, to drain the additional bleed. Here is the posterior pole retinotomy, and we had a satisfactory drainage of the fluid. Of course, the macular bleed was still there. The breaks were well lasered, and oil tamponade was used. As the good point about these cases, if the breaks are lasered and the retina is settled, this choroidal bleeds resolve very, very quickly in the postoperative period. But high myopes, even without a block perforation, can have these bleeds. And I think the fluctuation, even a slight fluctuation, the choroid is so thinned out, the vessels are so stretched out that the bleed can occur at any point of time. So you have to be very careful. I'd like the panel to make a comment on that. Thank you so much.
Pramod?
Yeah, I agree with Vishal, because choroid is thin, stretched, large choroidal blood vessels are not supported enough. So fluctuation in IOP, low scleral rigidity causing distortion of the globe, I think that can have a bleeding at any time. Elderly age, associated hypertension, again, this brings like a more added risk of choroidal bleed. So what you need to do is probably, I would say, minimize fluctuation of intraocular pressure, minimize distortion of the globe as far as possible. And I think wall cannula probably would be the best in this scenario. I think, and maintain pressure throughout as much as possible.
Can I add a point?
Yeah.
One of the conditions which you do pre-operative, just before you start your surgery, one of the causes was extensive, globe massage. the ocular
Yes.
massage after you give
Totally
the-
agree. That can also lead to the rupture of these vessels. Totally agree with that. Yeah.
Can I make a point, please?
Yeah, please.
If there's a large subretinal hemorrhage which has occurred intraoperatively, a massive subretinal hemorrhage like this, I have burnt my finger a couple of times by trying to remove this. Now I think what I will do is ask the patient to sit up, close the surgery, make the patient sit up, so that in the next few days, the whole blood settles down into the inferior quadrant. And then once it clots, then go inside and complete the surgery.
See what
What do you
happens is
think about
blood. Yeah, Gopal, blood clots very quickly, so it's not that easy to remove. And probably if it is not under fovea, if it is away from breaks, so it does not compromise your retinopexy and flattening the retina, except localized trap blood under the subretinal space, probably it sometimes makes sense to leave it as it is. I said, the minimum you do, the better in these eyes.
Yeah, they resolve very quickly over the time.
Yeah.
Anand, if there's no other questions, or
Yeah, we'll
comments,
move on to the next video because I think that's also related, so we can pick up the discussion a little more after that. Ramandeep also has a high myope, the posterior pole detachment.
Hi, everyone. This was a gentleman, one-eyed, who presented with a recent loss of vision. You see, he has this. He's been using this 22 diopters, lens there, and he's a really high myope. And we were. It was a RD limited to the posterior pole, and we removed the scetic membrane, and we really took. It was a long surgery. We were using walled cannulas. We were using 3D system, and we were taking all kind of precautions. And because he was really a nice gentleman, and when I started doing this laser there, then I encountered this problem that he started bleeding here, and there was some kind of a fluid there. So it was the steamy. It was a laser. When I was lasering towards the white area, the bare sclera started bleeding here, and you can see that he started bleeding from the inferior to the disc also, and this bleeding was pre-retinal. I went ahead and checked it, and so once I went inside to remove this bleeding, I couldn't remove it because blood was clotting. So I thought that let's leave this case here, and I filled this with the gas there. And eventually, this gentleman did well. He got his fairly 2400 vision back, and this is where I think the cause of bleeding, because I was using the walled cannulas, maybe the choroidal vessel got injured during the laser. So my question to the panelists: should we laser over the bare sclera area, or should we laser just the area where we should not touch that edge of the break? Thank you.
thank you. We'll go with Shobit first, and then Hemant and comments on this case.
Well, there could be two causes of bleed in this. When you remove the scetic membrane, that could have caused micro trauma to the small blood vessels, which bled when you did the laser, and second could have been the laser tip. These are the two possibilities, to my mind.
Hemant?
High myopes, I have seen, are more prone to it, and it is best to know when to stop to try and remove the blood in these cases, and better to leave them with gas. Silicone oil is not a choice in this situation at all.
I think the bleed occurs when you do it over the sclera is because we try to see that we see an observable burn, which is not possible. Because of that, you try to use a higher burn energy, and that's what causes the rupture, and that's causes the bleed.
Okay, Manish and Pramod, any comments? Otherwise, we move on.
No, I think it's the same, that the laser power at times erratically would cause a sudden bleed. The main thing is to raise the pressure right away and make sure that the bleed doesn't increase. And if you see it increasing, put a little perfluorocarbon enough on the posterior pole so that that bleed doesn't reach the posterior pole till you can stop it. That would be how I would tackle it.
Yeah, no more comments. Yeah.
So yeah, Pramod is already shaking his head, so he's probably tired. So okay, we go to the next question. Next one, Anand.
Yeah, we'll move on. I think, yeah.
So this was a case which I buckled around 5 years back, and this was a patient of ocular cutaneous albinism, an 18-year-old boy, and the patient was doing fine for 5 years. and he was a one-eyed patient, and then developed certain diminution of vision and RD and a PVD induction, as you can see the V's ring, and we did a PPV and oil injection. There was an inferior RD. You can see the buckle effect also, and we found an inferior lattice with hole. And fortunately for us, the PVD induction was already there, and we cryoed the area and filled up with oil. And unfortunately, there was a redetachment after 3 weeks under the oil, and this time there was a superior RD. And the problem here is the zero contrast, and we cannot find the breaks, and we can easily miss the primary break. So what we did was we filled up the posterior pole with the PFO, and created a iatrogenic large retinotomy, which we can see, and injected subretinal trypan blue through that, and just let the dye flow subretinally towards the break, and it came out through the primary break, so we could find out the causative break. So this is the retinotomy which we created, sufficiently sized so we can see it in the postoperative period. And you can see the poor contrast. The posterior pole is filled up with PFO so that the dye does not leak towards the macula. And now we are injecting the dye subretinally. And it moves towards the vent, the primary break. It's going there. And you can see it comes out through the primary break. And so we just blanket laser that area and cryo the interior part and fill the cavity with oil. And fortunately, the patient did fine after that without any recurrence after the oil removal also. This is the cryo. Thank you.
Thank you. Very nice technique. Again, it's not like every day we see patients who have an albinism and a retinal detachment. So problem becomes is getting uptake with the laser. That's why you have to obviously cryo and find the break. But Pramod, you're a specialist.
Yeah. I think it's excellent job he has done. I think there are two issues here. Extremely difficult to find the break because of lack of contrast. And second thing is there is no support for a choroid. There's a high risk of suprachoroidal or subretinal blood in these eyes. I think he has handled case very well. So, but I would have been still hesitant. I know I don't have choice but to do cryo because you can't see peripheral break and because laser burn will not take. But cryo again increases the risk of suprachoroidal hemorrhage in these eyes.
And Gaurav, I think apart from using cryo, which is the only way you can treat it, here the importance of Linkoff's rules come in because you don't see the break. So you go by the extent of RD and then empirically do cryo to those areas particularly.
Yeah.
But I think when you have already buckled eye, the Linkoff's rule will not hold very true because
that's
the
also
dynamics
true.
change.
Yeah, it does change.
It was a
right.
previously buckled eye.
Yeah, so maybe not this particular one, but yeah.
So one quick comment on this is there's an old instrument that a lot of the younger people who are listening may not have heard, but it's the intraoperative
Endocryo.
Endocryo.
It doesn't come in.
Can I make one point?
Comes in 20.
It's a 20 gauge.
If you inject sodium fluorescent intravenously during the procedure, can the sodium fluorescent detect the tear?
No.
I probably not because I think just so much diffusion. But I think what Vishal did was very nice of just using. Right.
Yeah. So I'm usually not a votary for creating one retinotomy to search for a primary break, but this is one rare example of where it worked. I know this technique people use in Europe fairly commonly to look for breaks, but I never seen the logic in making one break to search for another. But in this instance, I think this is one place where it's been done very elegantly. And thank you, Vishal, for sharing this.
Very nice, Vishal.
Thank you, sir.
Next case.
So I think with that, we come to the end of this segment. Dr. Hemant, are there any questions pertinent to this segment?
One of the questions that was, I think I can ask Gaurav about it. How would you ensure a good block in a patient who has been previously buckled? Because those are the patients who have a lot of problems. So one of the questions was, what care do you take or what special technique do you use to block these patients who are previously buckled?
Good question. I would say first is experience. So you can't really get that by, you just have to do them. But number two is I just try to make sure that I lift the globe when I'm doing it to make sure that I'm in the right space. And I think you have to trust your instincts, right? And so I don't typically, I use 1 1/4 needle, and I will only go about half or 3/4 of the way in. And usually if I do that, then that's not a problem. But that's a difficult situation because now you've changed the anatomy of the eye, right? The orbit. So that's now if you're really not sure about that patient and you need to do extensive work, then I think you may want to think about putting that patient to sleep if need be, because that's what general anesthesia is there for. But usually it's not a problem. But I don't think you should let the block dictate what you do with the surgery. If you need to do the surgery, do whatever is necessary. And anesthesiologists don't like to do general anesthesia, right? Because they have to work. So if they have to work, it's easy for them to watch us struggle. Well, this is a time for us to watch them work. So that's how I'd put it.
Yeah.
Okay.
Just one point I would like to add here.
Yes.
One point to add here is, particularly when you examine the fundus, look for hourglass appearance. If your band is too tight, and if you look and is hourglass appearance, sometime whatever giving block, you have a posterior to the buccal, that encerclage, this can be bulging of the sclera, and then the likelihood of perforating the globe. So if once you know that, then you can take care of, you can avoid that.
Now, there's one more question that, which was asked was, I think we should avoid repeated air fluid exchanges in high myopes, because that's one reason why you would have fluctuation of intraocular pressure and bleeding. So that was one of the tips that one of them. There are a lot of suggestions in the questions rather than questions per se. There are a lot of suggestions coming in.
Well, I think that then we have people for the next panel. I think.
Sure.
So Anand, we move on.
We'll move on to the final segment of this very exciting session. It's called Potpourri. It's a mix of many things. So Sai, can you share? Yeah.